So maybe I start the presentation, and I'm just looking where to get where can I do the presentation? Is there a chat, share screen? Okay, yeah, I can see it. So our aim with this study was to describe the prepartum anatomy of the abdominal wall and to find, like you said, the normal reference values. And here are the authors. And I'm Katarina, and it's doctor of naprapathy. So that is a physiotherapist, and then adding manual skills. So 5 years of studying. And then medical doctors and one radiologist. And we enrolled participants, and the inclusion criteria was 18 to 50 years. And the women had never been at any stage of pregnancy. And we enrolled 71 healthy women, and the mean age was 30.5 years. And the range was from 19 to 50 years that enrolled. And the mean BMI 24, and you have the range there as well. And all the examinations were conducted with ultrasound at one clinic with the same ultrasound by one operator, and that was me. And I have looked with ultrasound and registered with that more than 5 years with musculoskeletal imaging. And we looked at linea alba, and then we also looked at linea semilunaris. And I will get back to the semilunaris a bit later on. So the linea alba we measured with ultrasound, and we measured just above the umbilicus, the belly button. And then we choose the sites to measure, to register at 3 centimeters above and 2 centimeters below the belly button. And different studies sometimes measure at other sites, but we choose these ones recommended by Beer and Lee. And we also measured the linea alba thickness at all these sites. And looking, I'm going to show you some ultrasound pictures of that. And we also measure with a tape measurement to have the circumference of the abdominal wall. And this is an ultrasound picture, and this is the rectus muscle on each side and between the linea alba. And we measured from the most medial aspect of the muscular compartment of the rectus abdominis muscle from side to side. That is the width of the linea alba. And then the thickness from the most ventral aspect to the dorsal. And underneath, below the belly button, in some cases we found that there was no really distance, there was no really linea alba, so it was 0 measurement. And sometimes in some women, we found that the rectus muscles were lying kind of on top of each other. So we got negative values of the linea alba below the belly button. And here are our results. So the IRD, interecti distance, just above the belly button, the mean value we got was 1 centimeter. And 3 centimeters above, 0.9, and 2 centimeters below, 0.2. And here you have those negative values from negative minus 0.5 centimeters. And looking at the 19th percentile, then we got the measurements like you see on the rightmost column. And if we compare that to the normative, the reference values that are often used until today, then the reference values before these say that just at the belly button, the reference value is 2.7, then it's 2.2, 3 centimeters above, and then 1.6 centimeters. So everything below the umbilicus, 2 centimeters below the umbilicus, everything up to 1.6 centimeters often is seen as normal values today, but our 90th percentile was at 0.5, so that is quite different. And we also did all the measurements in standing, and standing with relaxed abdominal wall, and then standing balancing on one leg. And we did those measurements mostly to have reference values and to have those values to compare with another study that we are right now conducting and doing with women postpartum, 3 to 12 months postpartum, and to be able to compare the results from those two. And the linea alba thickness as well is there. And we used ultrasound, as that has a good integrated reliability, and that is a reliable instrument for evaluating abdominal muscle and fascia thickness. And then we also looked at the linea semilunaris, and that is the fascial connection between the lateral aspect of the rectus abdominis muscle, connecting with external oblique, internal oblique, and transverse abdominis, respectively. And as there are no really registrations or reference values for the linea semilunaris, we really didn't know where to start measuring. So we choose our measurement points, measurement sites, to be just lateral of the umbilicus, lateral of the belly button on the right side of the body, and then just below the coastal arch on the right side as well. And this is an ultrasound picture as well, photo. So this is a rectus muscle coming, and this is the most lateral aspect of the muscular compartment. And then drawing a horizontal line to where the external oblique comes in, the medial part of the external oblique, the internal oblique, the medial part. So this is also negative value. And then to the transverse abdominis as well, the medial aspect. And here are the results from that. And I'm not going to talk about everything, all the results, but we want to use these as well as reference values to compare with the postpartum study that we are conducting right now. And these values could be valuable as well when you're doing surgery and wanted to know what is the normative values for linea semilunaris. And then we did the tape measurement as well, circumference, and we choose to take the circumference with a tape measure at the largest, the largest part of the belly. And these ones as well are to compare with the postpartum group, especially, both lying supine and then standing relaxed and standing balancing on one leg. So our conclusion from this is that we support the new European Hernia Society guidelines from 2021 that rectus diastasis is a separation exceeding 2 centimeters. And we only had one participant presenting an IRD exceeding 2 centimeters. And that our data and measurement locations may serve as a standard for assessing linea alba and linea semilunaris in women. Yes.
Thank you. So let's start with the questions, Alexis.
Yes. So thank you for the presentation. You have, okay. So let's. Yeah. So we have prepared some questions that we will be discussing, and of course we will also be open to questions from the audience if they have. And obviously feel free, Pilar and everybody, to intervene and ask your own or to do any have any comments. So let's start with the latest statement from the study. So the current definition of diastasis recti is 3 centimeter, and the EHS guidelines recommend 2 centimeters, and your data supports this. But why should we change it, and what will this change mean?
Should I take it?
Yes,
I can answer that.
Yeah.
And why change it? Mostly, I don't know what European Hernia Society is thinking about that, but in my opinion, what we think is that you look at the normal values, and if the normal values are up to 2 centimeters, then everything above that is a change. So we looked at what is a kind of normal before you have those hormonal and structural changes in the body. And then most women have up until 2 centimeters, and everything above that is a change. So from 2 centimeters and up could be called diastasis recti. And today, diastasis recti, that is a widened distance in between the rectus muscles. So everything above the normal values, and that is kind of definition of rectus diastasis. And what the change will mean, I mean, when we look at the 3 centimeters as the reference values, looking at studies that had looked 1 year postpartum, then almost 35% of the women present with an rectus diastasis 1 year postpartum. And as the change, the rectus diastasis measurements, they change into 2 centimeters, then there probably will be a lot more women diagnosed with diastasis recti. So there will be a change, and then that I think then it's important to know that you have a diagnosis of diastasis recti. That doesn't mean anything that you have any problems or that you should have any pain. The diastasis recti, that is a measurement, and only a measurement. It doesn't say anything about function.
Yes.
Anders, do you have anything to?
Yeah, to fulfill Katarina, I think the discussion is good. And I mean, this study is an observational study of pre-pregnancy women and nulliparous women. And this measurement that we've got, it's the normal in this cohort, the normal measurement, the normal values before pregnancy. But what is postpartum normal is something else. And 2 centimeters or 3 centimeters, it's the purpose with this study was to have a baseline to compare with what we usually see in postpartum women. And the next step, what is a measurement for a decision of surgery, is something that comes even later on. But I mean, what we can say is the observation that we did on the nulliparous women, and I think that we support the EHS guidelines is from what we can see in up to 2 centimeters, the range of nulliparous women. I don't know if this clarifies anything, but
it also brings us a bit to the next question. You described a lot of terms that we could discuss, but one of them is the postpartum abdominal wall insufficiency. And the discussion, I think, is should we move towards this kind of definitions, like postpartum insufficiency or general abdominal wall insufficiency, instead of the diastasis recti?
In my opinion, I think that it would be very helpful, because the abdominal wall insufficiency, then we talk about the whole abdominal wall, and including both the linea alba and the linea semilunaris and everything else that could be stretched and elongated. And we know that some women have problem or function problems or pain when having maybe 4 centimeters of diastasis recti, but some women don't have any problems from 4 centimeters diastasis recti. So the diastasis recti, that is a value or a measuring point that is important to have. But I think that is one of many other points that should be, or things that should be looked at as well. So looking at the whole abdominal wall and more abdominal wall insufficiency, then that includes the linea alba, diastasis recti, and some other things as well. and also looking at having good questionnaires to look for answers for if you don't have any functional problems or pain or whatever. So those questionnaires are important as well.
Yeah. So, Phil, I would like to hear your opinion on this. Should we use like these two definitions, the diastasis recti as an anatomical description and the insufficiency as more of the functional outcome of this?
Yes, I agree with the definition of the IHS, of course, because we did the guideline. And I think 2 centimeters is the normal distance in nulliparous women. But we don't know what is the normal in multiparous or after pregnancy in most of cases. Perhaps 2 to 3 centimeters in this kind of women after childbirth is the normal situation, but we don't know. Perhaps we need to wait for the next study from this group. That could be very interesting. On the term of postpartum abdominal wall insufficiency, I think we need to develop this term in a very special way, because some time ago, perhaps 5 or 6 months, Snietansky published a paper about this exact term. Definition with lateral insufficiency, stretching the skin, and a lot of things. And we don't know exactly what this definition is. Perhaps we need to wait to the next study.
So besides the diastasis recti, you also made other of the linea alba, other measurements, as you said, on the
because not only it's interrectus distance.
Yes,
other things are important too, like obliquous muscle and transversus abdominis. I think is the more important muscle in the abdominal wall function.
and you also did a lot of functional measurements. And do we need? Do you see that there is a lack of functional data, that we need more of them?
Perhaps, but I think as we saw in this paper, the difference between supine position are in standing position are not very, very important. And perhaps we need to eliminate the measurement in a standing position, because it's difficult to measure. Not everybody do the same way, but in supine position it's very easy to measure, and it's more comparable.
A comment from the others, Anders?
Yes, one comment about the linea similonaris measurement that was based on partly clinical experience. We've been doing quite a lot rectus diastasis repairs, and mainly if we look at the functional improvement, it's very good in general, but in some cases the repair of the rectus diastasis wasn't sufficient. There was still an insufficiency in the abdominal core, and we found that some women have also a diastasis in the similonaris line, which led us to also repair the similonaris line to get a sufficient abdominal wall function and to restore the anatomy. So that was one of the decisions for looking further on the fully anatomy. And to take a step back, the term abdominal wall insufficiency, I think that was mentioned first by Philip Muysons, and postpartum abdominal wall insufficiency syndrome, I believe was his term for it. And I think this covers more of the function, yes, while rectus diastasis or linea semilunaris diastasis is more of anatomical measurements that is important for decision making, especially for surgery, but also for to get a global picture of the core function.
And talking about the functional definitions and data, did you see any relationship between differences in the measurements of linea alba and the semilunaris, and to that they have a difference in the functional data? So did you notice a relation there?
We didn't look at in this cohort. We didn't look for differences in the function compared to differences in the interrected distance or variations in the semilunaris line. So in this material, we couldn't see any. We cannot describe any differences in function.
Katerina, can I say it as abdominal wall instability? Is it correct? And is it not replacing, but in the large rectus diastasis, there will be pain in the backbone, and maybe the patient has unstable abdominal wall because of the rectus diastasis or semilunaris weakness.
And
is it a correct term, Anders?
Abdominal wall insufficiency, I think that's a good term to.
Yeah, I mean instability.
Stability.
In abdominal wall instability, I think that's instability or insufficiency. To me, it's same. It describes the condition. And as I understand your question, is it to repair just the diastasis in the midline? Does it help? And I would say in most cases, yes, it helps. And this has been shown by in our group. We've done a couple of cohort studies that clearly shows that repair of the midline, the diastasis recti, it provides a functional improvement. But
you go.
But in some cases, the improvement could be even better. And I think what I'm talking about is maybe the most extreme cases with not only a diastasis in the midline, but also diastasis in the semilunar line or other anatomical changes caused by pregnancy.
And this takes us a bit to a question from the audience that I think we can discuss right now, from Martin Simmons. He asked, how do you restore the linea semilunaris?
Yeah, that's there are different techniques. What we've been doing is medialization of the external oblique and suture it with the same technique as the rectus diastasis repair, with self-locking absorbable sutures, but suturing it up to the anterior rectus sheath. So medializing it.
Plastic surgeons do it a long time ago.
Yes, and it's
Sometimes,
described. It's been well described from Brazil. Professor Ney has published papers with this description of this technique, and yeah, it's well known to plastic surgeons.
Okay, so thank you very much. Let's move a bit on about the data itself. There's a lot of discussions lately about AI and use of AI in medicine and in surgery and decision making. Do you see a potential use for that kind of reference data combined with AI?
I can give my perspective of that. I'm a rookie on artificial intelligence. I've just started getting into the world of ChatGPT, but I see an enormous potential with AI, and but I think what you can do with it depends on what data you put in, and of course with the new basic data, I think the data from this work is important, but we need more basic data to be able to get reliable results from the AI.
Exactly. Perhaps we need more data about postpartum women.
Yeah, and directly to the next question, what are the next groups that you plan to study?
So we are right now doing a study on postpartum women, like you said, that 3 to 12 months postpartum. And then we are doing the same measurements. And in my opinion, it's really interesting and really exciting things that we are recognizing. And especially when comparing lying supine, doing the rectus abdominis or the IRD measurement, and then comparing that to standing. So that is quite different with the postpartum cohort than the Nulliparous. Just to give a kind of a bit of information there. And then we are following this Nulliparous cohort as well. So we are going to follow them 5 to maybe 10 years. And then we are crossing our fingers that they are going to get pregnant. we already have 5 of them being pregnant or has already had a baby. So then we follow them. I follow them at 1 month postpartum, 3 months, 6 months, and 12 months. So then we have a cohort of Nulliparous that we can follow 1 year postpartum, and that would be really interesting. And they are doing all the questionnaires, and we are doing the same measurements at all these appointments. And we're also looking into registering Nulliparous menopause women. So there have been studies like Kaufman and others that are looking at more like people from 18 to 90 years. And they say that as the age increase, the kind of risk or the IRD, increase of IRD is increased with age. And then we are looking now, we are starting to look at menopause women and to see if is it that way with women menopause, and is there any change if you have hormonal replacement or not. So that would be interesting as well.
And perhaps it could be better if your new study are only in 6 months post-pregnancy or 12 months post-pregnancy, because it's different between 3 months and 12 months. There is a very large time in which the abdominal wall recover after the time.
And we are trying to follow that by measuring both in 1 month and then 3 months and then 6 months and 12 months. So all participants, we are following all those sites. So 1 month postpartum, 3 months, 6 months, 12 months. So 4 appointments during 1 year.
Very good indeed.
It's going to be exciting.
I'm going to come back to the previous question a bit about the functional data. You do measure quality of life, function, activity, and do you plan to do more of this data to be able to perhaps define the threshold where insufficiency begins, abdominal insufficiency? So where does it actually start? Is that something that is also plan of your future research?
Yes, we were talking about that. There are a lot of good questionnaires, and all groups that are studying and doing research, you use different questionnaires, and maybe to look what could be kind of what studies could you have, like a baseline or base studies that we all use that could be usable. And that, Anders, you know more about that. We were talking about that. And
Nice.
Yeah, I can fill in with one more material that we have collected but not yet started to calculate and write on is another cohort with operated women, where we measured the waist circumference with relaxed and not relaxed abdomen, and the purpose is to try to find a proxy for the abdominal wall insufficiency, and the thought was to if the circumference might give a better picture of the insufficiency than measure all the anatomical changes. Might be, I think this could be really interesting. So we have the material on around 70 operated women with a 1-year follow-up.
yes.
Where we measured the circumference before and after repair.
We are excited about the results of this. Well, it will come. And what do you think the clinical use of this kind of data would be? Is it something that is immediate, or are we talking of something in the future?
I think mainly this work, the using daily clinical practice may not be the main purpose of this work. The main purpose is to have a baseline to know what the normal anatomy is, to compare the postpartum findings with a baseline or reference data. And so I think that's the most important. In daily clinical practice, we need more data on postpartum women.
And what about men?
Yeah.
Rectus diastasis in men.
Yeah.
It's a different kind of rectus diastasis.
Yeah, yes, it is.
Yeah, I think so. I agree with you.
Yeah, yes, it's men are differs in this perspective, of course, and we don't have that much experience of men with the rectus diastasis. We've been repairing a couple of, but much lower number of men with rectus diastasis than women. As from my experience, men with diastasis can have functional problems as well, and a repair can restore the function, but it's the experience is very limited so far. So I think we need to do more studies on men as well.
Yeah. Mm. And the clinical, sorry, the clinical use of this study, the Nulliparous, that could be for you as a surgeon, to surgeons to have the measurements to kind of look after surgery that have you, is it restored or not? Sometimes I meet a lot of women post-operatively, and I do the rehabilitation programs post-operatively from the SSC recti surgery. And often I also always look with ultrasound, and often they ask me that, yeah, but you can see that there's a linea alba there, there's a tendon in there. What is that? They are not, the rectus muscles are not really close to each other. But in what we have seen, I don't say that this is the way it is, or that this is true in any way, but what we have seen is that after 6 months, maybe 1 year, you often have a bit of a linea alba there. And in my thoughts, this is only my personal thoughts, I think that often that could be that you have to have the force transmission between the right and left body part. So you get a small linea alba in there, in between 0.5 centimeters up to 1 centimeter. And explaining that to the women that, okay, so before pregnancy, maybe the normal values, everything up to 2 centimeters is normal. And that is really a kind of relief for the women to say that, okay, so it's normal to have a small linea alba in there, because many think that when you do the surgery, the rectus muscles are going to stay really close to each other all their lifetime. And then when they discover that on the ultrasound, or they feel by themselves with their fingers, then they kind of get a bit worried.
And if I could fill in with one more aspect on this, I mean, we talk about the interrecti distance, but what the meaning of that, of course, it depends on what patient you have. Is this a woman of 40 kilos or 140 kilos? The size, a 3 centimeter diastasis on a 40 kilo woman differs from a woman of 140 kilos. So it's and in this perspective, I think maybe the waist circumference could be not a full answer, but we cannot look only on the rectus diastasis on that measurement. We need to look on at the bigger picture.
Yeah, and then also have those questionnaires with back pain, with Becke, and with back pain and other things, and how you move in your everyday life and all that. So we should have a kind of setup with different questionnaires to use to be able to decide whether if it is a problem or not.
Mm-hmm.
Mm.
Nice, exactly.
I have a few questions. First, I'd like to. I know that you look at the rectus thickness. Have you seen any correlation with the rectus thickness and the obesity of the subjects?
No, we haven't so far measured the rectus abdominal thickness in this study. So we only looked for the interrectal distance, but we have the measurements, so we have the ultrasound pictures, so we can go back and have a look there. But we did not include that in this study.
Yeah, we did similar, different, but rectus diastasis study, but we haven't published it yet. But we saw that with the obesity, the rectus thickness is decreases when they increases the obesity. We saw and as you said in your paper, that the elderly patients has more prone to do diastasis recti. So another questions about your primary diastasis recti repair indications, except accompanying midline hernia. What symptoms do you consider is due to the rectus diastasis, and you do the repair of the rectus diastasis with the patients?
Yeah, I can try to answer that one. This is a difficult one. What decision making for surgery, and I think it's not only 1 or 2 or 3 symptoms, it's I think it's you need to put in a lot of aspects before decision of surgery. But I think if we look on function, I think as in the present guidelines, first line treatment should be training, core training, and if core training can resolve the functional symptoms, it's good. But if the functional symptoms are resistant to core training, then surgery can be put on the table as an alternative treatment. And in my perspective, I try to figure that can surgery resolve the problem? Is there a diastasis wide enough to that can be repaired to provide an anatomical change that can restore the function? And so that's from the surgical view, and I think we need to collect the functional symptoms and discuss it with the patient. And as always with surgery, it's important to discuss risks and possible improvements with surgery with the patient. And so it's a good question, but it's not that easy to answer, because I think it's so many aspects to put in. It's not. It's much easier with a groin hernia. It's there, but this is a larger.
So do you have a cutoff value for repairing diastasis recti, for example? 6 for larger.
For me, I usually about 3 centimeters, but that's not a strict cutoff value. I've been repairing women with abdominal wall insufficiency, but a diastasis less than 3 centimeters, but in some cases a very weak abdomen, but in some cases a semilunar diastasis. So if we widen the perspective, not only looking at the diastasis in the midline, but at the global abdominal wall, so I think that could give us more and better information for decision making.
May I say something?
Yeah.
I think the important number is not interrectus distance. Is the most important thing is the symptoms that the patient had, because it's different if the patient has 25 years old or 55 years old, are completely different. And perhaps in a younger woman, only 3 centimeters, it's very symptomatic, but in a older woman, this diastasis is not symptomatic, and those don't need any repair. The symptoms are the key, in my opinion.
But you mentioned about the semilunaris insufficiency. What distance would you consider that there is
another cutoff value, Anders?
Yes, another cutoff value. That's a good one. I don't have a cutoff value for that, and I don't think there is one yet. And I think again that the important is to look at all the different parts of the postpartum abdominal change, and also, of course, to put in the level of functional disability, what I try to figure is, what can I provide with surgery? How much can I restore the the anatomy and what is the total improvement of repairing the midline, repairing the semilunar lines, and what will the surgery provide the patient. But I cannot recommend any cutoff for the semilunar line yet.
It depends on your examination on the wall, the laxity of the wall,
Yes.
circumference of the abdominal wall. My plastic colleagues do application of the linear seminars both sides to narrow the abdominal wall circumference, but it's it's plastic surgery, not repair or functional issue. But it needs studies for evaluate this kind of techniques.
Your next study is weight.
So, any more questions, or we can?
Do you have any more questions from the audience? No, I don't see any.
So Anders, you are not coming to Barcelona next week, huh?
No, I'm not coming to Barcelona, unfortunately.
Unfortunately, yeah. Next time,
It's a long trip from down under.
sure. It's like another planet for me.
Yes.
But I hope a lot of the audience will be coming to Barcelona and Sitges next week to take part in the 2023 Congress of the EHS. I think it will be a very exciting Congress with a lot of new things to see, a lot of discussions like this one, and more, and obviously in person. So from my part, I would like to thank you for being here, and give over to you for last comments. I'll start with Katarina.
The last comments.
Yes.
Thank you first for inviting us. It has been a pleasure, and I think it's really interesting to, like you started with, to look at what is before hormonal and structural changes. What does it look like before anything changes? And that should be maybe the first thing we should look at, and then being able to decide on, is there a change or not, and what kind of a change is it. So I think it's really so exciting to be a part of this doing these studies, and I'm looking forward to the next studies that we're doing and all the other ones doing around the world with women's health and the diastasis recti and abdominal wall insufficiency.
Yeah, very nice. I hope you can inspire more studies like this in other areas. And I see that in New Zealand it's starting to get a bit brighter.
Yes, it's morning. It's early morning here, but the sun is coming up. Yes, that's correct. Yeah, and I can.
The sun is going down.
Yes. And I'd like to say as well that it's an important issue. It's an important topic. It's almost half of the population, so it is important, but it's a difficult condition, and we need to discuss it more, and we need of course more studies, and we try to do our best to fill up with evidence and to learn more. And but I think this is very good, and I appreciate to participate in this journal club, and I think this is the right way to go.
So thank you very much for joining and your great contribution tonight. Have a nice evening all. See you in Barcelona. Okay.
See you.
Thank you.
Bye.
Thank you.
See you all.
See you. Bye.